We have my distinguished panel here, and so we're gonna, a common question for the MIGS mafia is, when do you use this MIGS versus that MIGS? And so we're gonna try to show some examples. So case one is a young man with pigmentary glaucoma and no cataract and wants MIGS. 42-year-old athletic trainer with pigmentary glaucoma, referred with an IOP of 25 in the right eye, 22 in the left on maximally tolerated medical therapy. His Tmax was 50 in the right eye and 35 in the left. Okay, so young guy, clear lens, amazing vision, athlete. He's got pigmentary glaucoma and all the stuff that goes with it. And he's had a PI. He's had SLT. Both eyes are showing progression. Both eyes need surgery. And I was his third opinion for treatment.
Can you tell us what his maximally tolerated medical therapy consisted of? I mean, you're talking about somebody who's really busy. That could be one drop.
Right. So, that's a good point. That fell off the slide. He's on Travatan and Combigan. So that's his visual field. It's getting worse. Okay. Severe glaucoma in the right eye, and you could potentially say moderate in the left, assuming that's a lid artifact up there. There's no way I'm going to let anyone do that surgery my dad had in the 90s. His eye has been totally jacked up ever since. So 5 years ago, this patient would have gotten probably ab externo canalplasty in both eyes in my hands, or maybe a Trab Express in the right because he's got such severe glaucoma and CP in the left. So what about now? You are not phacoing this guy. You got someone who's unless they have angle closure, you don't need to do phaco on someone who doesn't have a cataract just to treat their glaucoma if they're in their 40s and 50s. That's not necessary. And plus we have to think about why is this pressure elevated? So what do you guys think? What are your options, Jimmy?
So the problem is presumably there's pigment clogging up the trabecular meshwork. So the left eye was more moderate, and I think that would be amenable to a Cahook dual blade or any other kind of angle surgery. The right eye was more advanced, so I would go to probably, if he didn't let me do a trabeculectomy, I'd do a Zen.
Yeah, I agree on the left eye. I think any of the goniotomies would be a good option. On the right eye, sometimes as physicians we speak from our last mistake. And I have a recent patient. It was the last trab that I did. And it was a situation where, similar situation, pigmentary glaucoma, uncontrolled pressures, multiple drops, young guy. And he, basically had to do a trab because I could not get any of the other things supported. And he had a hemorrhagic choroidal about a week out. And for me, maybe at this point, thinking of that case, a 360 Omni with viscodilation and goniotomy would be maybe an option there because I've seen pressures come from 30s to low teens in those scenarios.
Pat, any thoughts?
One thing I would do is just, when I really wonder if patients are using their drops, is I'm just going to put a drop in your eye, and I'll put a drop of BSS in and just watch if they just spasm with the drop going in their eye, or if they squeeze so hard that they're not getting the drop in. So then I'm wondering, well, is maximum medical therapy something that we haven't achieved yet when they've done that? I had a patient whose pressure was 33 on 3 or 4 meds, and she came into me. And after we taught her to do that, her pressure dropped to about 15. But assuming that's not the issue, and I do fewer options than you guys, I think the Omni would be the one I would look at.
Yeah, so this is a guy that, you know, in the eye that had less damage, I think, you know, you know, doing the OMNI, getting rid of all the trabecular meshwork, that's pigment that's occluding it, you know, was successful. In the right eye, I kind of went back and forth on him. Someone that has a high pressure and has that level of glaucoma, it's not wrong to do the OMNI. And because of his particular pathogenesis in his young age, I said, you know, this might not get where you need to be, but it's going to be safer. And then I used the angioplasty, open heart surgery analogy. I'm like, listen, you know, it's kind of like, let's take you to the cath lab and see how it goes. But you may end up, you may be on the, you know, you might be getting a cabbage in the morning kind of thing. Like, so you need to be ready to be able to, and so how I would explain that was, let's do the OMNI. I'm going to follow you very closely. I'm going to see you post-up day 1. I'm going to see you post-up day 3. You know, if you have a pressure spike, I'm going to put a Zen in next week. You know, and so that's kind of, or we'll restart meds, and you know, maybe the following week. So it's that kind of, because it's a huge win if he's in the 70% in that situation. In my experience, that does well, you saved him from a bleb. Alternatively, you can put a Zen in, and you say, well, I can always do the OMNI later, which you can, which is cool, right? So. Good. So case 2, premium lens patient with mild glaucoma. 70-year-old lawyer, still in active practice, sent by an optometrist you co-manage with. Optom talked to you about extended depth of focus lens and MIGS. Listen, doc, I know the world's not perfect. I see that every day. I'm just sick of taking my readers on and off all day just to see my computer. I know I might have some glare and halos. I might still have to wear glasses, but my brother in Atlanta already had this surgery, and he won't stop bragging about it. So the caveat there is the dude's a lawyer, and don't be afraid to put a premium lens in, and he has realistic expectations, okay? So, you know, a little bit of astigmatism, right eye dominant, full visual field, a little bit of thinning on OCT, pressure's on 15 on 2 meds, okay? Has legitimate cataracts. Sure would be nice to get off that orange drop, doc. It hurts like heck. He didn't say heck, but you know, COS version. Hurts like heck. Patients needs phaco, mild glaucoma. You agree, premium lens. What do you do about his desire to be off one med? What are you going to do for him? Guys.
That's a easy phaco iStent inject for me. Premium lens, if it's really mild, I'll probably do it, but if it's more than mild, then I wouldn't do it.
What I ask these patients, and what Steve's already articulated, is what do you expect to get from the procedure? And if it's, I never want to wear glasses, I have to say, okay, we both want the same thing. We want a perfect implant, but perfect implants don't exist. So let's talk about what's out there that's best. And I said, you know, with the combination of implants, we may get you to a point where 90% of the time you're not wearing glasses. How does that sound? And, you know, get them to buy into what existing technology they have. I think the first thing I would do with this guy is I would check, you know, a lot of times they're dilated and they come back to me already. I would check his pupils in the undilated state and make sure the pupils are reacting properly. Because if you get this lag, this latency that's going on, they're not going to respond that well to a multifocal, or they're going to complain about, or even an extended depth of focus. They'll make comments in relationship to, well, I need the light, needs to be better. And then I actually get a tape measure out, and I give them something to hold on to. I don't prompt them, and I say, I measure what their reading distance is. You know, if they're 5'1" and they're up about 12 or 13 inches, that's a different discussion. Like the people from Guatemala, they're about 4'11". They would all get 4+ add multifocal if they wanted something like that. But for people that are on the computer, I say my spiel with the Symphony is good distance vision, good on the computer. You can hold it in your lap and hold it by your belly button. You'll be really happy with it, unless it's too small or you have to hold it too close. But this type of guy, he's motivated, he's educated. I'd proceed with that. You know, but I'd make sure his pupil was fine first, his tear film, do the regular, check on the regular things. But the iStent works great in this environment.
Any other thoughts, Matt?
I agree. iStent or Hydrus even in this case.
Cool. Yes.
Just probably Dr. Sweeney, you said you co-manage a lot with optometrists. And some of them are very active in their glaucoma treatment, but for you, you're doing these iStents
Yeah, well, I coach them up on it, and I try to, say, well, you can expect a little heme here. Some people are a long ways away from me because I'm kind of the east side of Dallas, but I'm pretty comfortable in doing that. I don't put eye stents in people that have, on Xarelto, whatever. I'm really reluctant to that, but I do tell them you're at a little bit higher risk of having a hyphema because I've seen that in patients, and so they have to be okay with that. But my experience is, and you're asking a great question, is I don't care what you tell them, they expect to see good within a few days. So, I have them elevate their head of bed because I had one guy lay flat, and he had a tiny hemorrhage, very small, but it was over his pupil, and he was alarmed by it. But, you got to prep them ahead of time. And if I sense that they're visually just uber demanding, then I may not do it if I'm worried about that situation. Or I'll tell the optometrist, we'll call them up, have a discussion with them, and say, if there's any sort of a hyphema, just call and let me know. And that usually works out pretty good.
Any other questions about sort of the mild glaucoma, phaco-MIGS, phaco-eye stent kind of situation, sir?
I got two questions. If I'm going to start out using an Omni, what do you guys recommend as far as anesthesia? Topical sedation, you put a block in for the first couple of cases? I just have a lot of trouble with people moving when I'm doing corrective surgery.
So the very first day that I did Omni, I did block. However, that lasted about 3 cases, and I feel like most people do really well, tolerate it very well topically.
Yeah, I mean, and I kind of individualize it for the patient, but it's if you're certainly when you're learning anything, I think that it's probably that you can't. It's okay to maybe err on the side of more anesthesia for sure, and you're more comfortable, especially because it takes you longer. But then once you get good, all these trabecular procedures, whether it's the Omni or the KDB or whatever, they don't take very long. You have to be very, very careful though to make sure you're in the right place. So with the Omni, if you kind of get into a false, or ABIC, if you get into a false passage or something, and if you start to go in the suprachoroidal space, that hurts, and so that's the other issue there with that.
I'll say the other thing that I have done is I'll use most of my lidocaine 2% at the start of the case, but I'll save about a quarter and put it right into the angle right before I go in with whatever stent or device I'm doing.
Same questions. Do you guys have any experience comparing the new irrigating goniotomes versus the Lake?
There's no data comparing those. Yeah, so you can only infer, but they should be very similar. I would think they would be similar. But who knows? Yeah, I mean, the gonotome just came out, so I don't. So, I wouldn't, how so?
Goniotome's like $3.95.
So isn't the KDB about that?
Not in my market.
No? You have to buy more of them. If you buy more at the same time, I think that you get a better price. But, ma'am, you had a question? Yeah, please.
Yeah, just to speak to what you're saying about sedation. So I've done a lot of these, and I have a really good anesthesiologist, and what I've learned is that it's pain when you touch it. So if you hit them with Versed, if your anesthesiologist hits them with Versed, right before you do your eye stent or whatever, there's no pain. It's easy.
So just give them a little more Versed right before you, okay, good. That's good advice. Yeah. Yeah, and that's whether it's, probably Versed better to give them than propofol or something,
Pain, right?
Yeah,
It's not about sedation, it's about pain.
right. It's good. Any other questions about phaco-MIGS, sir?
So the original eye stent with the configuration of it shunts the aqueous to the side. When you're putting that in, I've noticed that you can kind of treat it like a KUV and kind of leave a little landing strip. Do you ever find any utility in using that to make sure you're in some canal or to maybe titrate up and put on a protector going forward?
I think early on, I haven't done a G1 since the G2 came out, so it's kind of irrelevant. But I think everyone should probably switch to the G2 because two is better than one. We have the data to support it. If you want to do a goniotomy, do a goniotomy. I think, but maybe, I certainly did a few good drags of the TM before letting it sit into place, usually for a clock hour. But no one's ever studied that for sure. For sure, no one studied that. So, all right. So, case 3, older pseudofake on maximally tolerated medical therapy. Pressure's controlled, but forgets to take meds. So, 80-year-old woman with primary open-eye glaucoma goes to her doctor once a year, takes no medicines except for her glaucoma drops, like none. Vision's 20/20, moderate nasal step with visual field loss, mild progression. Pressure's always under 14 when you check it. I travel all the time between my vacation home in Scottsdale and visiting my grandkids in Tulsa and San Francisco, and I often leave my latanoprost in the fridge and other drops on the nightstand. SLT was done last year when pressure was in the 20s. Very healthy. Mom is still alive at 103. Options. So 80-year-old, full of spit and vinegar, healthy, no systemic meds, on 3 meds, getting worse, but controlled. If she actually took her drops, she'd be controlled. But, she's having compliance issues. You're going to be like, well, do better taking your drops, Yeah. So, no. So, gentlemen.
It sounds like your SLT was very effective. Your pressure was 20, and now you're 14 with no drops. So,
No, she's still on drops.
I thought she wasn't taking them. So,
She's not compliant with them.
Yeah.
She's supposed to take them. They're 14 when she takes them, I guess. But her visual fields are progressing. So her pressure is kind of is sort of irrelevant. It's kind of like you need to do something for her.
I'd want to implant a bimatoprost SR in 6 months.
So that's a very good point. So this is someone you might be able to just say, you know what, just wait, do your best. I appreciate this is not suboptimal right now. I actually have a few patients that I'm kind of like sitting on that I'm just like, you know what? Ordinarily, I would probably have done this, but just like nothing bad's going to happen in the next 6 months. So that's yes. Any other thoughts though? Like, say you didn't have. What if you didn't have that coming out next year?
I'd probably refer.
You'd refer. He said I'd refer. That's awesome. All right. So Matt, what are you going to do? You sent to Matt Rouse.
It's going to be a long commute. So I think this would be a patient where if she truly is advancing, it's always playing in the back of my mind here 2 things. One, okay, you've got a little bit of advancement, and she's forgetting or just not taking her drops. So I'm also starting to transition to that. Is there a little bit of dementia?
No, she's bright, sharp as a tack. Okay. Mom's 103.
Well, then if she's 103, I'd go back to kind of what I said during my talk. I'm going to build from the inside out here even still, because I've got at least 23 more years that I've got to keep her pressure down. So this would still be probably a canal surgery for me. That's probably what I would look at.
If you had to pick one,
yeah.
What do you think?
There's
no wrong answer on this.
Either like a
right?
like a 180 Omni or a Cahook.
Yeah. So
I guess the confusion for me is that pressure of 14. I didn't know if that's because she just used her drops yesterday, but she doesn't normally use her drops because any of the canal surgeries aren't going to get you lower than 14 for the most part.
Maybe I didn't present that case well. The deal is her visual field is progressing. So even though her pressure is 14, you've already done SLT, so you can't do SLT. That's why I kind of threw that in there. But her visual field is progressing, and she's confessed noncompliance to you. So it really doesn't matter what the pressure. It's kind of like the hemoglobin A1C. It's like it tells you, how well controlled their blood sugar's been over the last however long. So her if there was a hemoglobin A1C for glaucoma, it's maybe the visual field, and her visual field's telling you that she's not well controlled. And this is important too for you to not, there's lies, something lies in statistics, so, and sometimes the data you get can be deceiving, so.
I guess the question to me, though, is I'll treat her differently if she's uncontrolled at 14 than if, what's the target? Is 14 what you want to get to, consistently 14? Because then I think those are good options. But if you're saying 14 is not good enough and she's getting worse, she's more normal tension-ish.
I'm saying she's not compliant. So what her pressure is doesn't matter, because sometimes it's 14, sometimes it's probably 25, sometimes it's 10, who knows? We don't know, unless we send her home with a home eye care monitor, I forgot to put in one of these talks. That's been a huge game changer, is a home. We actually have, you can actually, get a home eye care monitor, and it doesn't read the pressure on it, so the patients don't call you in the middle of the night with, oh, my pressure's so high, and then I have significantly changed my therapy on patients when I've realized that they had a 15-point delta between their peak and their trough of their pressure. So huge deal. So yeah.
Do home eye care monitors encourage better patient compliance?
Who knows? You would think so, but that's not. I mean, I can't give you an evidence-based answer. I can only give you. I mean, it's the forces of logic that have caused you to ask the question, and so it would seem so. Yes, yeah. So sorry, Jamie, if I didn't present this case. Maybe I didn't present it well enough. But
So I've got a question for you guys. Let's say bimatoprost inject is available. How are you going to position that in terms of, well, it didn't work well enough, now what am I going to do next? Because you've got that device sitting in the AC. Are you going to go in there and do an ECP with that sitting in the AC? Or are you going to do a canal procedure? Are you going to do the canal procedure first and then do the bimatoprost second?
her issue is really compliance. So
Well,
I don't think that
just
it would,
down the road, I'm just saying.
I don't think it would, you would stop her one drop, and I think you'd probably be, I mean, I think your answer, bimatoprost, I think that's going to be what most of us are going to do for her. And quite frankly, you may even be able to get her off the other drop, because the bimatoprost SR is probably going to work better than the topical bimatoprost ever did anyway, because of what it's doing. And then I wouldn't worry about, I mean, you have more experience with the SR than I do. I mean, I wouldn't necessarily worry about doing another procedure with that in there, would you? No. Yeah, just because it's so small. I mean, it's just, itty bitty. Any other follow-up on that case? So, all right, we're getting there. And then we're able to unpack some questions in the process. This is going well. So, case 4, 60-year-old pseudophakic high pressure, maximally tolerated medical therapy. So, visual field has an inferior arcuate in the left eye, on 4 meds in the right, 1 on the left. Had phaco alone in the right eye because the visual field was full. But on 3 but they were on 3 meds at the time. So, here we go. Patient at 5 years ago when the vision was 20/20. And when they had the phaco on the left eye, they had, I don't know why this is unpacking this way. It's really strange. Okay, let's start over. So patient had phaco 5 years ago, and the vision was 20/20. Full visual field in the right eye last year. Now there's an early inferior nasal step in the right eye. So the right eye is getting worse. Visual field has an inferior arcuate. Pressure's 30 in the right eye, 12 in the left, 4 meds. So right eye, pressure 30, 4 meds. Visual field's getting worse. Pseudophakic. Left eye had a phacotrab, done a while ago, and that's stable. Here's a patient that had, when the visual field, this illustrates something. The visual field was full. The doctor decided to just do phaco because they were controlled at the time on their 3, on their meds. And now the patient has a visual field loss and an elevated pressure on those same meds. So, what are you going to do with this patient? Right eye, pressure 30, on meds, progressing.
I think it's a shame that they missed the opportunity on the right eye the first time to put eye stent in or something like that. depending on how quickly it was getting worse and how severe it was, I'd probably do a canal surgery, like a hook dual blade or something like that. If it was really severe and more advanced, then I might think about a Zen.
Yeah, I think this is one of those scenarios where you're going to wonder what your goal is on medicines, or do you want them completely off medicine, or are they going to tolerate and take one or two medicines? Because I think the canal surgery probably is getting the mid-teens and one
Yeah.
med.
Relatively young guy, no problem with meds.
So,
So,
I think canals.
supposedly,
canals,
no problem.
Canals are reasonable again, inside out. I think canal is probably the first step.
Yeah, and he's
unless-
got his visual field, he's got an early defect. I mean, early defect. And he may still have needed something, even if if he had gotten a phaco eye stent. He just may not have lost visual field. You may have caught it in time. But yeah, there's a bunch. I mean, there's no one right answer. I mean, you could even make the micropulse argument, probably, if you really wanted to. Particularly if there's some reason you couldn't get him to the OR, you can do micropulse in the office or something. So that was good. So I've left a little extra time here for questions. So we have a few extra time for a couple minutes for questions. So we're actually going to finish on time.
So when you, maybe this is for James, when you've been inputting the SR and you're not doing cataract surgery, you just make a paracentesis to implant?
Yeah, it's actually just a little 27 gauge needle track. So it's not like a 15-degree blade or anything. It's just you stick the little needle in and push the little plunger and it floats away.
And it's in the study it's a slit lamp or minor OR.
Yeah, it's a minor OR for the
right.
study. So I do it in the LASIK room, but
But it's going to be a slit lamp procedure.
It's going to be a slit
right?
lamp procedure.
Yeah. Other thoughts?
If you're doing phaco for those patients later, do you need to take those out so they don't go somewhere else in the eye?
No.
Estimate amount or anything?
Some of them during the study go behind the iris, and you can't follow it, but the pressure, it still works, and we don't worry about where it is because it's biodegradable.
Yeah, and I think a lot of times too, they may become adherent to the angle, and so they probably wouldn't break loose. So
If you're doing cataract surgery in an end-stage glaucoma patient, do you avoid MIGS?
So cataract surgery, end-stage glaucoma patient. Do you avoid MIGS in a cataract surgery with an end-stage glaucoma patient?
I'm probably a little more conservative than these guys, so I might. I don't have that tool that I would use as much. I haven't done Omni, but I'm sure he has a different answer.
So if it were in stage and are they on medicines or not? I mean, there's times that I would, if I need a low pressure and I would still consider a Zen, because 10 years ago I would have done phaco trab maybe on that patient. There have been some scenarios where I've had advanced disease in like a 90-year-old and they need a cataract surgery, and I've been less aggressive in those circumstances. So I've actually, and I don't have a big enough N to give you a great data point yet, but I've had some anecdotal success with actually phaco micropulse. And so I'll do the micropulse at the start of the surgery and then take the cataract out. So
I have a patient recently that's been like this, that I was like, you know what, you need cataract surgery, but your pressure was like 40 on 4 meds. It was when she was sent to me, and I was and she's got central islands of fields. I'm like, let's not worry about your cataracts right now. like the cataracts, I can always take your cataracts out. Like let's give you the best glaucoma surgery for your situation. So I did a Zen on both eyes, and then eventually if the pressure creeps up a little bit, which it does, because even for her, 15 is not appropriate pressure. Then you can go later on and go in and do phaco eye stent or phaco omni or phaco whatever to get the rest back. And you can also do that combined with, if the pressure's not quite good enough or you're seeing some encapsulation, maybe even doing a little enhancement of the Zen at the time. Maybe inject a little, I would certainly consider injecting more mitomycin at the time of the phaco MIGS Zen enhancement, kind of thing. So, thinking outside the box, or not, there is no spoon. Matrix quote.
I found that if I do like a phago trab, together, it doesn't work as well as if I do one by itself. So I'll try not to combine the procedures. Like I still consider Zen like a trab, like it's in the same
Right.
class of when I would do it. So if the pressure's 40, I would do the Zen or the trab first and leave the cataract alone because the trab will work better.
Yeah.
If-
See, Jamie, we did the same thing.
If the
We did it the same.
Same thing.
We did it.
One of the things I've been learned, right, I've done someone's control with just doing a cataract. Oh, look, I'm gonna help you out with
Right.
this eye stent, and I've got a high chemo with a pressure of 40, right? I mean, like day one,
Yeah, but that's transient. You just wash it. I mean, wait or wash it out, and that's a different scenario. I mean, that's
right.
you know.
But in stage glaucoma, I'm getting more aware because, of that possibility, right? So
If they have end-stage glaucoma, don't do phaco eye stent. That would be a mistake.
glaucoma doesn't take away.
Don't do phaco eye stent if the patient has end-stage glaucoma. Yeah, you need to, that's particularly if they're not controlled. I mean, you could make the argument that if their pressure's 10 on one medicine, they have end-stage glaucoma and a cataract, you can do phaco eye stent. But I mean, if that's what we're talking about, that's one thing. But if you really need to, if you're struggling with their pressure control and they have a cataract, they have end-stage glaucoma, eye stent's that's not your best tool in that. That's bringing a knife to a gunfight, I'm afraid. Yeah. Sorry for my chronic pugilism. Other questions? Awesome. We're going to finish 2 minutes early. That's fantastic. All right. Guys, thank you so much. And thank these guys who are so awesome.